I'm going to talk about the low-cost technologies with special focus in its applicability at the low resource settings. I have no conflicts of interest. This is the outline of my presentation. We'll talk a little bit about disease load first, then we will review the full spectrum of screening methodologies, then we'll focus on low technology methods, then high technology methods, but always with focus in its applicability in low resource settings. Finally, we'll talk a little bit about the appealing approach of self-sampling or vaginal sampling. Okay, what about disease load? Cervical cancer is a real health problem worldwide. It's been calculated that almost 500,000 new cases are produced worldwide per year, and from that, 85% corresponds to the so-called developing world. So cervical cancer is a disease of inequity. The region only manages about 5% of the global resources devoted to cancer fighting. And also, cost is a real constraint for cervical cancer screening in low-resource settings. That's why we should look for low-cost alternative to the classic system. This is the full spectrum of screening methodologies, going from the simple cytology to the sophisticated molecular biology, biomarkers, and HPV testing. But we can divide these screening methodologies in two groups: those corresponding to low technology, which is not a synonymous of low cost, not always, and they are represented by cytology and also by visual methods with acetic acid and Lugol's iodine. And the other group is high technology methods represented by HPV testing and molecular biomarkers. Let's take a look at the low technology methods. The first one is cytology. But is cytology really a low-cost methodology? Apparently it is, but we'll see that the system based in cytology is quite a complex. Cytology has been capable of significantly diminish the amount of cervical cancer in industrialized countries, mainly in the northern hemisphere. And here you have the result of implementing effective screening systems in the Scandinavian countries. A significant decrease in incidence and mortality due to cervical cancer was observed, but there is no such example of success in the so-called developing world. And there are many reasons trying to explain this failure. Some of them are related to the test itself, and others are related to the relatively complexity of the system. Cytology was adapted worldwide without criticism many years back, but now we know that its sensitivity is not as good as we expected. The sensitivity of cytology is around 55%, is far from satisfactory, and obliges us to repeat the tests frequently in order to overcome its low sensitivity. And that's why it is costly, because in the low resource settings, there is no enough organization and there is no enough resources in order to support this kind of approach. Liquid-based cytology was expected to improve the sensitivity for high-grade CIN detection, but now we know that there's little evidence supporting this. The main virtue of liquid-based cytology is providing us with an adequate preparation for better reading. Another problem is that the classic cytology-based screen programs have many steps. If any one of them failed, the entire system will be jeopardized. That makes the system kind of complicated, requires a high level of organization, and also requires significant investment in terms of economic and personal resources. That's why we have looked for alternatives, low-cost, low-technology, or low-cost alternatives to be applied in low-resource settings. Another low-cost methodology is visual inspection using a diluted acetic acid. It is kind of simple methodology. After applying 3 to 5% acetic acid solution for 1 minute to the cervix, if we see this aceto-white lesion with well-demarcated and elevated borders in the transformation zone, then we will get an immediate result. We'll be able to take an immediate therapeutic decision. That's the main virtue of visual inspection. And it's cheap, it is not invasive, can be applicable at primary level, and also can be performed not only by physicians, but also by non-medical health personnel. And the main virtue is that give us an immediate result, but also have problems. Of course, it's not perfect, and the main defect is the significant proportion of false positives. So VIA training requires an adequate initial approach and also good supervision and monitoring in order to keep a high quality of the system. The TATI project, one of the first pilot projects testing the see and treat approach using visual inspection coupled with cryotherapy, was conducted at the Peruvian Amazon jungle province of San Martin at the beginning of this century. We got very interesting lessons from that pilot project. One of those is that VIA cost is much lower than cytology, of course much lower than liquid-based cytology, and of course much lower than hybrid capture that was used in a subpopulation in that study. But the use of VIA coupled with cryotherapy should be used under the philosophy of see and treat. Another interesting lesson we got from the TATI project was that it is very difficult to manage from the screening and treatment point of view in one session. The one session management rate in the TATI project was below 30%. So the modern concept is not see and treat in one session, it's fast management. The sooner the better, the closer the better. So we recommend fast management, meaning that no more than 2 interventions should be taken, and no more than 15 days, ideally. We were the first to test the approach and the appealing approach of see and treat in the developing world in the 90s. At that time, we were able to demonstrate that one session CIN management was capable of adequately manage almost 70% of our patients. Initial studies about VIA sensitivity, cross-sectional studies, evidence of sensitivity going from 49 to 96. A pivotal study published in 2005 by Lynn Denny group for the first time evidenced the impact of VIA screening on high-grade CIN reduction. That study also evidenced that HPV screen and treat was better than VIA screen and treat. In 2007, Dr. Sankar's group published an article evidencing for the first time the impact of VIA screening on cervical cancer incidence and mortality. And finally, 2 years later, a kind of controversial article published by the same group evidenced that HPV screening was the only methodology capable of diminish the amount of cervical cancer in terms of incidence and mortality, compare with cytological screening and VIA screening. Only HPV was capable of diminishing cervical cancer mortality. But after that, there were interesting studies like this one, kind of meta-analysis of more than 20 studies, evidencing that sensitivity was good, 80%, with a good specificity of 92%. Additional cost-effectiveness studies, kind of mathematical computerized modeling conducted by the Harvard group, led by Sue Goldie, with Peruvian data, evidence that 1 or 2 interventions in a lifetime using HPV DNA technology was the best in terms of disease reduction or disease control, but was followed very closely by visual inspection in 1 or 2 interventions in a lifetime. So at present moment, we will say that VIA is still a useful tool to be applied in many parts of the developing world, where they have nothing at present moment in terms of secondary prevention. An additional plus is that VIA will create an infrastructure for screening, educating medical and non-medical community. The third low technology method is visual inspection with Lugol's iodine. If you see this area with yellow saffron or yellow lemon color, then a high-grade lesion will be present. The immediate result will allow also for immediate treatment. And studies about VILI sensitivity by Dr. Sankar's group revealed a sensitivity of 95%, very high. But these good results hasn't been reproduced in posterior studies. An interesting study conducted by Raúl Murillo in Colombia comparing cytology, VIA, and VIA and VILI evidenced a slightly better sensitivity for VIA over cytology, but the most important finding was that coupling together VIA and VILI, he improved sensitivity to 68% with a good specificity of almost 91%. So the main constraint to use VILI in the developing world is availability of the Lugol's iodine. It is very hard to get Lugol's iodine solution in many parts of the developing world, as we have experienced in many parts of Peru. Okay, low-cost technology, high technology. Now we will review HPV testing and biomarkers, also focusing in its applicability in low research settings. So HPV testing are represented by those methods amplifying the signal, and hybrid capture is the best representative. It's a very well-validated methodology by millions of tests run in the last 10 or 15 years all over the world. It is standardized, reproducible. Then we have those amplifying the target. The genome and PCR is, of course, the best representative, but PCR had some problems at the beginning in terms of contamination and also implementation, but in the last years, some commercial products have been launched into the market and trying to get, and they're actually getting a place as primary screening methodologies. The main virtue of HPV DNA testing, and I'm not going into more detail, is its good sensitivity, well over 90%. That is unbeatable if we compare with cytology sensitivity. That's why we are convinced that in the future, HPV technology will be the primary screening methodology. Another virtue of HPV testing is it's a very good negative predictive value that allow us to increase the intervals between the screening interventions to 5 years or even 10 years with no problem. But again, the main constraint to widely use high technology like HPV screening in the developing world is cost. But the cheap, reliable, and affordable HPV technology based in hybrid capture already exists. It's the CARE HPV that was invented, let's say, many years back. It's under validation now, and we're expecting, I think, a little bit long for its approval for being used wide openly in the market. Recently, many days back, it's been approved by the Chinese agency equivalent to FDA. It's kind of simple technology. It's been intended to cost less than $5 per test. It is intended to get the result in 2.5 hours. You can see that the reagents are colored in order to avoid mistakes during the processing of samples. It can run batches of 45 or 90 samples at once, and it was intended to be used in a campaign kind of intervention, screening intervention. It's very simple. You don't need a sophisticated lab in order to process samplings. You see that you need a simple table on the lab. It doesn't require running water. And initial studies conducted in China revealed a sensitivity of 84% compared with hybrid capture, which was over 90. There is a little drop in sensitivity. So in many parts of the developing world, probably in the near future, the approach will be screen using carrier HPV as a primary screening tool. Negatives will be scheduled to be returned in 5 years, and positive will have a second test. There is no agreement in which one is the best second test, but it's probably that we will use VIA as a second test after HPV positivity. But in this situation, we can use VIA in 2 ways. One as a diagnostic tool or a triage tool. If we use, this is initial data, recent data by from PAT, and it's been demonstrated with a small number of cases, of course, that if we use VIA as a second diagnostic test, meaning that we only treat with cryotherapy positive VIA women, then we will observe a significant drop in sensitivity. I think it's unacceptable, 48%. But if we use VIA as a triage tool, then we'll keep a good sensitivity of 81, 82%. So probably in the future, the role of VIA after HPV positivity would be as a triage tool. And a little bit about self-sampling. This is a very interesting approach. Self-sampling or the so-called vaginal sample, and initial data also generated in China by Dr. Lin Qiao evidence a sensitivity of 82% compared with the cervical hybrid capture test sensitivity of 95%. So there is a little drop, there is a drop in sensitivity, but this is a price to be paid if we want to increase our recruiting potential, our potential of coverage of the target population that, in my opinion, will be potentiated in 4 or 5 times. Let's take a little look at the oncogenic process. It's very important. HPV is omnipresent, so HPV testing can be used in any part of the oncogenic process, but we must be very careful. If we use HPV testing very upstream, then we will get a lot of non-significant transient HPV infections. So it's better to go a little bit downstream and start at age 30 in order to focus our screening on high-grade CAN. Papa Nicolau and visual methods also focus on high-grade CAN. And finally, the new molecular biomarkers go a little bit downstream, trying to identify those events, really marking the potential for progression to more severe lesions or invasive cancer. So we have a variety of molecular markers, cellular as well as viral, including proliferation markers, overexpressed cell cycle proteins such as P16. Methylation also has been intensively investigated recently, of course, mRNA, and also oncoproteins such as E6. But again, the main constraint is cost. But this method has been developed. It's a cheap kind of strip test trying to find the oncoprotein E6 of HPV 16, 18, and 45. It's under validation studies. Initial data evidence the sensitivity of this E6 test is around 67%. So there is a drop in sensitivity with a reasonable specificity, or good specificity of 99%. So with this data, we should say that E6 test detected 2/3 of CIN plus lesions with very high specificity. So the place for this test probably would not be as a primary screening method, but as a potential triage tool for women after HPV positivity. Of course, more studies are needed. And finally, we should say that there is no universal recipe, that the molecular technology can be applied if we get enough reduction in costs, and we advise a given territory or a given country to make kind of mapping in order to identify those areas with, according to characteristic of poverty or inaccessibility, in order to be selected as ideal places to implement a fast management program using low-cost screening methodologies. So in conclusion, we will say that there is no universal recipe, but now we are living very exciting times because we have a broad spectrum of affordable options for secondary prevention, including HPV testing methodologies to be applicable in low resource settings. Thank you.
Thank you, Carlos. Are there any questions from the audience? Yes.
No, please.
Can you step up to the microphone?
No, I was just wondering who in the audience has experience with VIA projects? Can you please give us some feedback? Because you seem to conclude that this is an option that worked well in your country, but there's controversy on that, and I think it would be helpful for the meeting to step out with some more clear idea if this is a real option, is an option that should be promoted, or still in doubt about that. Can you give us some feedback, please?
Hi, my name is Mauricio Massa from El Salvador. We've worked with VIA for a few years now, you know, we've been. It's the constant discussion whether, you know, in a PAP-based system, whether you should start implementing VIA or not. But as Carlos said, I think the way you have to look at it is obviously you have to do a screen and treat approach. And when you start thinking about the treatment, that's where VIA is like really powerful in many ways, because it's not about the test, it's about the treatment that women will receive in really rural areas in the country. For example, in El Salvador, we would never do a PAP test near a clinic that has, you know, access, a woman has access to PAP or a colpo. We would definitely just do it in rural areas where we know that when we get access to that women, you know, to the women in that area, that's their only way that they'll probably get their treatment. So it's more about giving more access to the treatment, I would say, than focusing on whether it's a good screening test or not.
Yes, I agree with that. You know, with other technologies, screening methodology, you have to wait for results. And this is critical in many parts of the developing world. In Peru, we have places where women have to travel by the river for 5 hours in order to get the nearest health post. So she won't come back for results. We need to apply see and treat approach. And VIA, I think, is ideal for that. And also, of course, there is a criticism based in overtreatment. Of course, the main defect of VIA is a proportion of false positives. But this number can be reduced if we have good initial training. And finally, I should say that it's a price to be paid. It's a calculated risk, a price to be paid if we want to increase our disease control. And also, it's important to remark that cryotherapy is a relatively innocuous therapeutic methodology. There is no mortality related to cryotherapy.
Is there another one?
My name is Sharon Kapampa, coming from Zambia, and we've been using VIA screening since 2006. And it's now nationwide. We have over 19 centers and moving on to about 10 more centers by the end of the year. We have screened close to 100,000 women to date, and it's a screen and treat. Women come in, they have their VIA done, and we're able to offer cryotherapy to 80% of the women who accept, and we have a 20% who usually go back home. They say they want to go and discuss with their partners or with their family. And like the presenter has mentioned, I think overtreatment is probably a price that we have to pay with VIA. But in a setting where we have nothing else that can exist, we used to have cytology, but if you, from the time for about 10 years in our country, or from independence about 1964 to 2005, only 10,000 women had been screened in their lives. Most of the women who come in from through our program, 95% have never had a pelvic exam, meaning they've never had a PAP. So VIA and making sure that they have treatment there and then is probably something that should be considered in low resource settings where there's nothing else that can be done.
Last question.
Yeah, thank you for the nice presentation. You mentioned one of the big issues for introducing HPV detection is the price. And my question goes whether the revolving fund initiative, for example, could play a role in even lowering the price of the suppose $5 that could cost care HPV, and because this would be really a major impact. And I think in the future guidelines that WHO will publish soon, they will strongly recommend HPV DNA testing. So it's important that we go together and try to lower these prices. Any experience on this approach?
Yes, we are convinced that the future of screening is HPV testing all over the world, even for low-resource settings. And I'm also agree that it's possible to negotiate with the industry in order to get good lower prices in exchange for a big volume on test. And also can be the revolving fund mechanism for PAHO or can be used. And I think that the care HPV will be a solution, but we are waiting, I think, too long for a care HPV. I hope it will be available in the market soon for low resource settings. But also with the classic HPV testing systems, I think the price can go down and it can be negotiated. It is interesting to keep that in mind.
Thank you.